Another aspect of atopic dermatitis therapy is that what we're directing our therapy towards can be changing. So the good and bad news is that there's a broad set of targets, and as practitioners, you should be aware of the different targets that people are going for. So some of them are rather specific in terms of certain cytokines. So we have an IL-4, IL-13 target, and there's a combo IL-4, IL-13 drug approved in parts of the world. IL-13s are well along the way in phase 3 trials. IL-31 is well along the way in trials as well, which is directed more towards the itch of atopic dermatitis. There are multiple other targets of things that you may not have known mediate atopic dermatitis and may mediate atopic dermatitis, but are seen on gene expression analysis or on other studies. And they're totally different targets. There are groups that are targeting the bacteria of atopic dermatitis. Can we replace Staph aureus with other organisms that compete with Staph, or organisms that aren't seen in atopic dermatitis skin but are seen in non-atopics? Can we transplant them back on the skin, not just to get a better microbiome, but impact on the course of atopic dermatitis? We have customized emollients or moisturizers that are trying to potentially change not just the barrier function, but potentially to decrease the sensitization of skin in early life to see if we can prevent atopic dermatitis. So I think as practitioners, you'll sort of be dragged through these changes as targets get worked out. And if a target is effectively targeted so that we mediate disease in a way that's safe and effective, then we'll know about it. JAK inhibitors, for instance, we talk about JAK inhibitors as though it's one type of drug, but there's 3 different, signaling JAK receptors and a TYK receptor as well. There's going to be drugs that block different aspects of that. So we'll be sort of dragged through the change in knowledge, but in an exciting way as we have new therapies to help us mediate the disease. So one of the unanswered questions in atopic dermatitis is whether early aggressive therapy will change the course of the disease. And that's the way I like to word it, because I don't know if it'll change the natural history, but I am pretty certain it'll change the course of the disease. So what do I mean by that? So if I have a patient who has spiraling, worsening, or consistently severe atopic dermatitis, I know more now about the impact on that individual. I have better data on how many nights they're going to be up during the week, on their sleep disturbance, their higher rates of depression and anxiety. I know they're going to have higher rates of bacterial infections as well as viral infections. And I know I've seen already that with more aggressive therapy, whether it be group topical therapy or systemic therapy, that individual lives are totally changed. Families come back from a child who's been on a new systemic therapy and they're like, their lives are changed. The family's sleeping better. There's actually a study recently on maternal sleep disturbance and maternal depression in individuals with atopic dermatitis. So we know if we effectively treat individuals, we're immediately changing the lives of the individuals. So I think serially over time, we're going to affect them as well. We still have unanswered questions about whether early aggressive treatment in early life will turn off the disease process and really change the natural history for that individual. I think there's a lot of promise. I think certain agents will be able to do it. It's just going to take a lot of years of research for us to figure that out.